Good morning. I'm Dr. Balasubramaniam Tyagarajan. Today I'm going to discuss the topic drooling. Drooling is actually defined as the inability of the patient to hold saliva within the oral cavity. What happens is when the patient is unable to hold saliva within the oral cavity, it tends to dribble out of the mouth. That is known as drooling. At the outset, let me tell you that drooling is more or less common in infants and in extremes of old age. In infants, what can cause drooling is the inability of the child to hold saliva inside the oral cavity because of the poor development of the oral musculature and inability of the child's tongue as well as muscles of the mastication to push the saliva into the posterior portion of the oral cavity to enable the child to swallow. So, drooling is in fact normal in an infant. So, within the age of 4, drooling is common in nearly 20 to 25% of the children. If drooling is present even after the age of 4, then it is a cause for concern. So, let us get into this topic of drooling and let us also explore the various problems associated with drooling and how we are going to manage these problems. Of course, management of drooling is actually a multidisciplinary uh, approach. It needs a multidisciplinary approach. So, I'm going to tailor this lecture from the standpoint of a otolaryngologist. So, drooling is always defined as the involuntary loss of saliva from the mouth. And as I told you at the introductory stage, it is a normal feature of infancy, but it becomes rare in normal children as they start developing the oral motor control, the sensory awareness of saliva within the oral cavity. And that is the most important aspect because if the child is aware of the presence of saliva inside the oral cavity, automatically it has a tendency to swallow the saliva. But drooling beyond the age of 4 is actually considered to be abnormal. And I should also wish to point out that drooling is little bit different from sialorrhea. Sialorrhea is actually increased secretion of salivary fluids. So when the increased secretion of salivary fluids is also known as sialorrhea, this can be caused due to so many conditions. But sialorrhea is a different entity from that of a drooling. Drooling per se can be divided into anterior drooling and posterior drooling. Anterior drooling is commonly the presence of saliva in the anterior portion of the mouth, causing it to dribble outside the oral cavity. And this should definitely be distinguished or differentiated from that of the posterior drooling, where there is always a risk of spillage of saliva into the larynx, from the pharynx into the larynx, and the child or the person or a patient who is suffering from it has a tendency to aspirate, and these patients have a real issue of problems associated with aspiration. Patients invariably they have episodes of coughing and they have uh, episodes of choking, and in fact becomes very obvious when the child is either supine or when it is lying down or when the child is sleeping. Child gets up with a bout of choking or coughing, and these children invariably present to the physician with episodes of recurrent pneumonia. This is as far as the anti-drooling is concerned, and drooling should be considered to be distinctly different from that of hypersalivation, which is actually excessive production of saliva. So majority of the children who drool do not hypersalivate. That should be borne in mind. And these terms like hypersalivation and drooling are not interchangeable, and they should not be used in an interchangeable manner. So let us go into the causes of drooling. I have already told you drooling may be normal in a young children, children say up to the age of 4, and this happens because some of these children have a delay in achieving motor milestone. Actually, drooling is could be considered as a swallowing disorder due to impairment of the oral phase of the swallow. So these children have a inability to maintain lip closure. They can have altered oral musculature tone, and they have impaired sensation and difficulties in controlling their tongue movements, and these can lead to decreased efficiency of swallowing, which in turn can be a cause for drooling. So drooling is in a child is invariably accompanied by dysarthria or unclear speech, and these children have difficulty in swallowing solid food, and these children are termed to be suffering from oromotor dyspraxia. This problem is specific to the oral cavity, and these children invariably present with no other developmental issues. But majority of the children who drool also present with associated disorders of muscle control. It can be due to cerebral palsy, and I should stress again and again, drooling is not associated with salivary gland pathology, or in among the saliva when it is being produced, excessive saliva being produced. So I should re-stress and stress again, drooling is not associated with salivary gland pathology or hypersalivation. And aspiration is actually a feature of bulbar palsy. Aspiration, again I repeat, could be a feature of bulbar palsy. So prevalence of drooling. So this is I've been telling from the very beginning that drooling is a common problem in children with neurodisability, and 50% of children with cerebral palsy, of course, have this problem, and parents do not always know that effective treatments are available. So this should be stressed. Parents of these children with cerebral palsy and who have a common problem with drooling, they really do not know that effective treatments are around the corner. And drooling, actually, they can consider drooling to be a trivial problem when compared to the larger complex problem which is being faced by the child. And these children could suffer the discomfort of drooling from skin excoriation, and they commonly present with wet clothing, and is considered to be a social embarrassment. And treatment, in fact, treatment of this specific entity can go a long way in improving the quality of life of the children, and the family also should benefit from the treatment. And let us get into the history and examination of these children. The physician should always focus on the direct and indirect evidence of aspiration. Nearly a third of these children who drool have shows and invariably show signs and symptoms of aspiration. And the history of choking or history of sporadic spasmodic coughing should be sought, and that too during night. And history of repeated chest infections again should be focused on and should be elicited. And children who do not aspirate, in fact, can safely be observed, because there is plenty of time to see the effects of growth which has on the development of the muscles of the oral cavity and the oromotor skills of the patients. And the child can be trained or can be tutored with certain oral cavity, oral muscle strengthening exercises, or it can also be taught to improve the oromotor skills by a series of exercises. Non-invasive treatments should be considered, and it should be reasonable, but surgery should be deferred till the child is a minimum of 6 years of old. And then this drooling is creating a lot of problem. If the child aspirates, treatment should not be postponed. I wish to caution again, if the child aspirates, treatment should not be withheld, citing the age of the child. So, all these children troublesome aspiration features. If the doctor is able to, physician is able to elicit positive history of aspiration, as well as the child has a history of repeated chest infections, this is actually an indication of video fluoroscopic examination or fiber optic evaluation of the exact swallowing process of the child to identify the area of concern. Again, this is actually a small algorithm which really helps otolaryngologist to choose a children who needs treatment, and also to decide what type of treatment modality to follow. Now, the first question the otolaryngologist should address is there a suggestion of aspiration on the history? For this to happen, the patient the patient's attendant or the parent should be clearly asked, should be diligently asked about signs and symptoms of aspiration. This, what could be the signs and symptoms of aspiration? Whether the child gets up in the night with a fit of cough, whether the child has choking attacks, and whether there is a history of recurrent episodes of respiratory infection. If the answer to this question is going to be yes, this is the time when the doctor needs to subject the child for assessment. So, on assessment, the first step a doctor should do is to attempt to modify the diet of the child. What can happen is, if the child is on a liquid diet, thickening of the fluid diet can help a long way. Then postural advice. The parent can be advised to feed the child while making it sit in the lap, or being holding the child in a lap in a upright position, so that the chances of aspiration is minimized. So that is more important. The posture of the child during feeding can be monitored and can be staged. And reflex management is actually prevention of reflex esophagitis, because these should not be put to bed immediately after feed. So what can happen is, increased reflex can cause increase in salivary secretion, leading on to worsening of drooling. So reflex management is again a must. And then you can go and restrict the fluid intake of the child, thereby thickening the fluids. And then you can tube feed the child using a Riles tube or feeding tube. If all these things are not working, then you can manage the child by surgery for correction of or prevention of reflex esophagitis. Even if that is not happening, then anti-muscarinic drugs can be started, which will reduce the amount of saliva secreted. Or even if it is not working, then botulinum toxin injection into the salivary gland again can reduce the quantum of saliva being secreted. And if all of these are not working, the surgeon comes into play. They can do a submandibular gland excision followed by parotid gland duct ligation. So then, if all of these are not working, the last but not the least is laryngotracheal separation and total laryngectomy. This should invariably be avoided, and this last therapy is just meant to for the sake of completion I am describing. The laryngotracheal separation is not advisable at all, or the physician or the attending doctor should go that extra yard to ensure that the child does not need this drastic procedure. So if there is no history or suggestion of aspiration, if it is a no, then you should always look out for hypersalivation, look out for reflex esophagitis, which can stimulate hypersalivation. Elicit from the parent drug history of the child. If the child is on nitrazepam, which is commonly prescribed for tonic-clonic seizures, again can hypersalivate. Presence of dental caries again can cause hypersalivation. Finger chewing habit of the child can cause hypersalivation. If these causes can be identified, it can be treated. If these causes are not identified, then look out for nasal block. If the nose is blocked, go ahead and treat. If the nose is blocked, what happens is the child has a tendency to breathe through the oral cavity. If the child is breathing through the oral cavity, to prevent the oral cavity, drying of the oral mucosa, the salivary glands has a tendency to hypersecrete. So the nasal block can lead to hypersalivation, and hypersalivation in a child can cause drooling. If the nasal block, history of nasal block is not there, then go and assess the developmental history of the patient. The oral awareness of food or liquid inside the oral cavity, and the oral motor skill assessment of the child is rather important. And the parent should be willing to comply with the various types of oral exercises which the physician is suggesting. If the parent is willing to comply with exercises, a trial, 6 months trial of exercises can be given. Invariably, it could be successful. If these exercises tend to be a failure or if they're not tolerated, you can always consider a trial again of anti-muscarinics, which could be a success. If the trial of anti-muscarinics again fails, you need to go to botulinum injection of the salivary glands. If the botulinum injection again fails, the submandibular gland duct transfer, what happens is you can transfer the submandibular gland duct a little posteriorly so that the saliva, secretion of saliva occupies the posterior third of the oral cavity, thereby prompting the child to swallow saliva. And the child won't be able to hold on to the saliva if the saliva is secreted into the posterior portion of the oral cavity. If all of these things are not working, you can go ahead and ligate the parotid gland duct. So at this juncture, I would like to give a small brush up of the physiology of salivary secretions. The basal salivary secretion, nearly 90% of the basal salivary secretion basal secretion is given by the submandibular gland, and the rest 10% comes on from the parotid and other minor salivary glands. But when the patient is seeing food, when the patient or when the child is having a look at the food, or when the child is hungry, when the child is eating, parotid gland takes over. Parotid gland secretion dramatically increases when the child starts to feed. Now, a child's general development should be assessed. In any case of drooling, the general development should be assessed. History should be elicited pertaining to developmental delay. And most children with sialorrhea will have general developmental delay. Then it can often be associated with the neurological disorder like cerebral palsy. And if the children does not shows no evidence of underlying neurological diagnosis, it is always worthwhile asking questions about speech, questions about chewing, swallowing, social interaction in general, and whether the developmental milestones were normal. These history should be meticulously sought. In young children, drooling can actually be an early sign of autistic spectrum. This should always be borne in mind. Drooling in a young child could be an early sign of autistic spectrum, or it could be early sign of oromotor dyspraxia. Then causes of hypersalivation. I have already told you drooling is different from hypersalivation. Hypersalivation causes escape of saliva from the oral cavity. So that can clinically present as salivary drool dripping out of the oral cavity. So the causes of hypersalivation again can be ruled out. So the child history should be sought, whether the child has habitual finger chewer, and history regarding gastroesophageal reflex should be sought for, because gastroesophageal reflex can increase salivary gland secretion. Nitrazepam usage, that too in seizures, in the treatment of seizures, can cause hypersalivation. It's actually drug-induced hypersalivation. Dental caries can cause hypersalivation. So these are all the common causes of hypersalivation which can lead on to saliva escaping from the oral cavity. Then most of the children with complaints of drooling, invariably they produce normal volume of saliva, and their basic problem is controlling the saliva, swallowing of the saliva. And some children can genuinely produce more saliva, that is you call as a true hypersalivation. But children with dyskinesia, cerebral palsy, or hyperkinetic oral movements can increase salivary secretion per se, leading to drooling. And open mouth posture is again another cause for drooling, because the inability to seal the lip is an important cause for drooling. So these children can be positioned in such a way that saliva does not drip into the school book or computer keyboard, and the books or the computer can be placed in a slanting manner, so that the child, when drooling over, or child will not be able to lean over to view the keyboard or a book, so that the posture where drooling occurs, that is leaning over posture where drooling occurs, should be prevented. The idea behind this positioning of the child while reading or while working on a computer is to prevent them from leaning over. The moment the child happens to lean over, drooling starts. So, inability to maintain lip seal is again an important cause. I have already been telling nasal obstruction can lead to excessive salivation. Nasal obstruction can keep the mouth open, leading on to drooling. And then adenotonsillar hypertrophy again can cause oral breathing, keeping the mouth open, leading on to drooling. And then dental malocclusion again can cause open mouth posture, leading on to drooling. Poor trunk and head support. This calls for a wheelchair modification so that the child will be held straight and upright, preventing it from falling over or preventing it from leaning forward. The leaning forward position should be avoided at all costs to prevent drooling. Next is let us go into the aspect of investigation. Actually, there are various scales by which you can rate drooling. The commonest and the most early of these scale happens to be the teacher's drooling scale, and this is rated on a scale of 1 to 5. And then there is something called drooling severity and frequency scale, where the severity of drooling is rated on a scale of 1 to 5, and then severity of frequency of drooling is again rated on a scale of 1 to 4, and both these scales are combined together to arrive at a final scoring. In fact, in majority of the scenario, clinicians overlook this aspect of assessment of the patient. So then there is something called drooling quotient. This actually measures the frequency of drooling in two standardized periods of 5-minute intervals. One is at rest and one is at the time of play. So this is ideally done with the child sitting up and 1 hour after the meals, because while the child is eating, the amount of saliva secreted proportionally increases, it shows a tremendous increase, and thereby drooling is common when the child is feeding. And then the parent of the child can be given a questionnaire whereby they can clearly indicate the severity of drooling. On the aspect of quantitative assessment of drooling, you can do a cotton weighing test where you can place cotton swabs in the floor of the mouth and then weigh it before placing and after placing, taking into consideration the weight of the cotton ball. If the weight of the cotton ball is going to be heavier, then naturally the excessive saliva or the salivary drooling is taking place. And then presence or absence of aspiration is another important pointer towards deciding on the investigation. If the child has a history of aspiration, always go ahead and do endoscopic examination of the act of swallowing, fluoroscopic examination of the act of swallowing, or functional endoscopic examination of the act of swallowing. In most cases where aspiration has been identified, a neurological cause should always be ruled out. And in the absence of neurological cause, always look out for tracheoesophageal fistula. It should be diligently sought for. In most cases, without aspiration and without, in most cases with aspiration and without any neurological cause, tracheoesophageal fistula should always be suspected and ruled out. Then I have been already telling about the role. It is actually a multi-specialty oriented therapy should be given to these patients. So the role of speech and language therapist they have a vital role to play in rehabilitating these children. So they can the child should be referred to them to the speech and language therapist, and they should specify and train the child with certain exercises which could improve the strength of lip closure. And this can be done by holding a wooden tongue depressor between the upper and the lower lip for increasing length of time. And they can assess the safety of the swallow while observing the child during eating, and associated issues with speech and chewing should also be addressed by the specialist. and they should take care to assess the oral motor skills of these children, and they should be in a better position to judge whether behavioral therapy or motivational therapy will help these children. And the jaw strength and stability again can be increased or strengthened by holding a tube between the molars and asking the child to keep it between the keep it hold it between the molar teeth while the therapist attempts to pull it out of the mouth. So that is again another exercise which can improve the oral cavity closure. And then the child mirror can be used while the child is feeding to provide visual feedback on the way the child is eating, and parents of these children should incorporate these exercises on a regular basis. And straw drinking from a straw should be encouraged, because while the child is attempting to drink from the straw, the fluid directly hits the posterior pharyngeal wall and the swallowing reflex is initiated. The first oral phase of the swallow is bypassed, and there is very little chance of spillage of liquid from the anterior oral cavity. And the thickening of the feeds can go a long way in preventing drooling, and behavioral modification can improve life of these children. And together with this reinforcement therapy, this will go a long way in reducing drooling in these children. And then there is dental surgeon. Again, they have a role. These children should be treated if caries present, dental caries, hypersalivation tends to occur. So caries should be treated. And I should like to warn you, drooling does not predispose to caries. It is vice versa. Caries causes increased salivation, thereby leading on to drooling. And then dental services can go a long way in improving the oral hygiene, and orthodontists can prescribe intraoral appliances like ISMAR, and this can provide good lip closure, thereby preventing drooling. Then pharmacological treatment of drooling. I have been already telling you the role of antimuscarinics. Antimuscarinics is actually an anticholinergic medication which is commonly used in the management of drooling. These drugs actually act by stopping acetylcholine from binding onto the receptors in the nerve cells, and thereby the amount of saliva secreted is reduced. It reduces actually the volume of salivary secretion. But one should be wary of the flip side, because saliva has a tendency to become thick and unpleasant when antimuscarinics are used. Again, these children can have bladder retention, causing frequent episodes of UTI. Constipation again is common in children whom antimuscarinics have been used. The other side effects of antimuscarinic drugs are dry eyes, dilated pupils, then worsening of seizure control, hallucination, sleep disorders. All these things are a problem. The common antimuscarinic drugs used are scopolamine, glycopyrrolate bromide, and trihexyphenidyl hydrochloride. Among these drugs, trihexyphenidyl hydrochloride is available in a liquid form, in a syrup form. So the best way to administer a drug to a child is in the syrup form. So trihexyphenidyl hydrochloride is a common antimuscarinic that has been prescribed to these children. Hyoscine hydrobromide is available as skin patches, and it has a basic advantage of ease of use. So the child need not consume it. All it needs is this patch can be stuck to the skin, and this patch is also waterproof. So it is sufficient if a full patch is given every 3 days, and that is more than enough. So a full patch every 3 days. Hyoscine hydrobromide patches, a full patch every 3 days is appropriate for most children. Then botulinum toxin injection. This is actually derived from Clostridium botulinum bacteria. There are seven types of botulinum toxin, but only type A and B are used medically. These toxins produce their effect by blocking the acetylcholine binding, acetylcholine release, in fact. So, botulinum toxin produce their effect by blocking the release of acetylcholine. So, equal amounts of botulinum toxin, that is A and B, are injected into the submandibular and parotid gland. So, equal amounts of botulinum toxin drug is injected into the submandibular and parotid glands. The optimal dose in children happens to be 80 to 100 units. 80 to 100 units of Botox. That is 4 units per kg body weight. So, optimal dose, I repeat again, in children is 80 to 100 units of Botox, that is botulinum toxin, coming to 4 units per kg body weight per day. So, this is given as a single dose. So, if this single dose is given, this reduces the secretion of saliva. The effect lasts anywhere between 3 weeks to 6 weeks. Next is surgery. The role of surgeon is you can perform if there is nasal obstruction, if there is adenoid causing obstruction to the nasal breathing, go ahead and perform adenoidectomy. And then to prevent reflex esophagitis, one can perform a fundoplication procedure. Then submandibular gland duct transfer to the inferior border of the tonsillar fossa. This can again prevent drooling. Submandibular gland duct transfer to the inferior border of tonsillar fossa has been practiced with reasonable amount of success. And then you can go ahead and remove both the submandibular gland, that is bilateral submandibular gland resection. So these are all these surgical methodology is reserved only as a last resort. And then laryngeal protection surgeries, I personally condemn this. Laryngotracheal separation, very difficult to achieve, and the best way to protect larynx from aspirations, to remove the larynx, that is total laryngectomy, the rarest of rare surgery that should be performed to alleviate the problems of these patients. Thank you.